Good afternoon, everyone. My name is Mark Hargreaves. I'm the Acting Deputy Vice-Chancellor for Research at the University of Melbourne, and thank you for joining us this afternoon. I'm sure it'll be a very interesting and stimulating conversation. Let me begin by acknowledging that we gather on the lands of the Wurundjeri, Wurrung, Boonwurrung peoples of the Kulin Nation, and I pay my respects to their elders past and present, and recognise First Nations people as the first innovators on this land. The Innovation Practice Program is the home of innovation teaching within the Faculty of Engineering, along with some other initiatives such as biodesign, and you've got brochures there on Ignite and Spark, which are some of the programs that the IPP uses to catalyse innovation skills acquisition by students, but also to provide valuable opportunities for industry partners to develop their own innovation capacity. This afternoon, we have the privilege of hearing from Sharon Lewin and in conversation with Peter Cebon. And if you reflect on the events of the last couple of years with the pandemic, and I remember hearing Sharon in early 1920 saying, 20, sorry? 2020. What did I say? 1920. Oh no, it wasn't. That was the last pandemic. No, my apologies. 2020. Sharon said, "Oh, we love viruses. We love new viruses." But if you reflect on what happened, there was a whole lot of innovation. I live in the inner eastern suburbs, and restaurants redesigned their business models. In fact, one local restaurant told me that they made more money during the pandemic by offering home cook takeaway services than they had in recent times. So lots of innovation, and we saw the rapid, when there's a concerted effort on the years of basic research, often overnight successes, usually on the back of very strong foundations. So mRNA vaccines were developed and implemented and deployed at warp speed, so to speak. So our speakers this evening, Melbourne Laureate Professor Sharon Lewin is AO, an eminent infectious disease researcher and physician, and the inaugural director of the Peter Doherty Institute for Infection and Immunity, and also the director of the recently announced Cummings Centre, Global Centre for Pandemic Therapeutics, which is a development taking lessons from the COVID-19 and looking to catalyse further innovation in diagnostics and therapeutics. And Associate Professor Peter Cebon, who leads the Innovation Practice Program. Prior to joining engineering here at the University of Melbourne, Peter has his background in engineering and in management, and he's consulted to a number of large organisations on their innovation strategies within the Melbourne Business School. So please welcome Sharon and Peter, and I look forward to hearing their conversation on lessons in innovation from a pandemic. Thank you.
Welcome. So Sharon and I met and talked about this, and I decided that there were three broad areas where key themes in innovation management intersected with her experience in the pandemic. So I thought that we'd spend the time together talking about those three things. One is about in every venture I've ever heard of, there's always someone who's advocating for the science and the technology, but they have to sit within an interdisciplinary team of people in disparate other fields, like marketing and manufacturing and all that sort of stuff, and they need to get their voice heard. And Sharon had many roles in the pandemic, being the science person, sitting among people in the business community and policy communities and so on and so forth. So I thought it might be interesting to hear about her experience of actually trying to inject the scientific message into the discussion. The second thing that I thought would be an interesting thing to talk about is that we teach our students a lot about the importance of what are known as edge cases, the value of going to people at the very extreme edges of a user community to see what you can learn there and see whether you can incorporate some of that back into the mainstream. And the Doherty was very heavily involved in the development of the response around for First Nations Australians. And so we thought we might talk a bit about that and what we might be able to learn from that. And the third thing which I thought was fascinating is the extraordinarily, well, from where I sit, the extraordinarily difficult leadership challenges the pandemic threw up for actually running the Doherty and its role in the response. So I thought the third thing we'd talk about was that. But before that, I thought I might give you all a bit of PTSD and actually remind you of what the pandemic was all about. So I've written this, I'll read it. But at the start of the pandemic, we'd been through SARS and bird flu, and this was more of the same. And other than there being some restrictions on Chinese students coming to the university, it was business as usual. Then suddenly people realized this was serious, very serious. We went into a short lockdown, and then horrifying news started coming out of Italy and New York, and short became long. And everyone became very inwardly focused, and they were trying to work out how to protect themselves and their families, and how to completely redesign their work, their families, their domestic situations, their domestic relationships, their social lives, and how to live and work and educate their children in completely new ways. And then medical systems in other countries started to become overwhelmed, and we had to make plans to protect our own. And then we learned that with well-managed quarantine, zero was a possibility. So we changed our goals, but the virus mutated and became more contagious, and people became less compliant, and we discovered that well-managed quarantine is hard. And then we learned what it's like to work in nursing homes and numerous other low-paid service jobs in our society that we'd never really appreciated. And then there were vaccines, but they weren't in Australia. And then they were in Australia, and then there was AstraZeneca vaccine, but it had rare side effects. And then there was vaccine hesitancy and misinformation campaigns and merchants of doubt and cures that didn't cure and then cures that did. And then we started to hear more and more about long COVID. Is anyone feeling sick yet? And then there were more mutations and it became more contagious. And then eventually everyone was vaccinated or had the disease and people stopped dying, and we've slowly gone back to this sort of new normal. And that's not too different from the old one. So that's the journey that we wanted to sort of explore a little bit. So Sharon, in this role of Chief Technology Officer, you were the co-chair of the NH&MRC Centre of Excellence for Pandemic Preparedness and Response, which is called the PRIZE, from about 2016 or something. You're also the co-chair of the National Health Advisory Committee for the Chief Medical Officer, and you sat on the Victorian Treasurer's Advisory Committee on Pandemic Response as the scientific member. Yeah. And so the first question I have to you is that Australia, compared to many countries, had an extremely effective science-led response. How did that happen?
Well, that's an easy question to start with. First of all, thanks, Peter, for focusing the discussions on COVID and a new angle on COVID, I think, because most people are really sick and tired of talking about COVID-19, and my experience is that everyone has a very strong view about how we responded. But I think the most important thing is that we don't go back to normal. We can go back to normal and sit in a room like this, but we do need to change the way we think about preparing for emergencies, how we respond to emergencies, and what worked really well in COVID and what didn't work well. And if we forget this all too quickly, we'll be caught out next time.
Yep.
So I think this conversation is great because we can talk about stuff that really worked and stuff that didn't work so well. Now, getting back to the question you asked me, because you did a long intro, just get back to the question.
Science-led response.
Science-led response, okay.
How did it happen?
Yeah, so I will just give you a little bit of background of where I came from in the pandemic and where the Doherty came from, just to sort of set the scene a little bit and why we were able to have quite a lot of influence in those very early discussions, because at that time when people were thinking, oh, just another SARS, this is no big deal, we were absolutely embedded in what was happening, which was all late January 2020, February 2020. So my background is I'm an infectious diseases physician and virologist, and spent most of my career working on HIV. And HIV is a very, very significant pandemic, but playing out over 40 years, which was very different to this one. And as Peter mentioned, I also was leading a national network around pandemic preparedness, which was set up by the Australian government in 2016 in response to bird flu, which happened in 2001, and we hadn't really responded that well to it. And then the Doherty Institute was set up in 2014. It's a joint venture with the University of Melbourne and Royal Melbourne Hospital. It's focused on research, education, public health, and we have a lot of expertise in virology, in all different viruses, and we have diagnostic labs, basic scientists, clinicians, and the gamut of people that you need for the response. So when this all happened, we were very well placed to first of all, set up testing to diagnose people, and second of all, to access information from around the world about what was happening. So right through January, I first heard about COVID on January the 6th. I can remember exactly the moment I heard about it. It was from a Chinese patient of mine who asked me, do you know about this pneumonia in Wuhan related to a seafood market? And actually, I hadn't heard about it from any of my networks, through the Prize network, through all of my colleagues at the Doherty, through my networks in HIV. And I looked it up that night online, and I found a report from the BBC about it, but that was it. Then on December the 10th, it came out that it was a coronavirus, and many of the people at the Doherty got to work on January the 10th, 2020, in setting up diagnostics, in setting up a test, being prepared for that first case. And so we already had very good relationships with government, state government and federal government, even though we're separate from government, because of work that we've all done. Many of my colleagues across the Doherty had already done in influenza and HIV and viral hepatitis, etc. And so when this was all unfolding, we were the first place to we diagnosed the first case of COVID in Australia, which happened to be in Melbourne. We helped set up testing for COVID around the country, and we were the first to grow the virus, which was a really big deal in January, and I can talk more about why that was a big deal. And so we were very well placed. So as this was unfolding, we had already done quite a bit. We were out the blocks early. All of us were talking to our colleagues right through January into February around the world, so able to access information. And therefore governments came to us really wanting advice. And it was built on, it didn't just come about in COVID. There'd been years and years of working together with the state and federal government. And some of my colleagues, particularly Jodie McVernon, who ended up leading a lot of the mathematical modelling, had worked for decades with the federal government around modelling around influenza. So that close partnership with government was in place. And I think for me personally, leveraging from my HIV experience, if you want to have a big impact on public health, you can't do it in isolation as a scientist. You have to do it in partnership with people that can make things happen, which are our politicians and, of course, the community. That's a whole nother story.
And then as the pandemic progressed, it all became much, much more political, and the politicians weren't as interested in the science in terms of the way they were talking. How did, obviously the underlying scientific advice was, didn't change, but how did you change your advising strategy as your influence declined? Relative influence declined as other things were started to get given precedence.
Yeah, I don't sort of see it like that. I think the decision making became much more complex because there were many more things to weigh up as the pandemic went on. At the beginning, there was sort of no choice. We had this new virus, a population of people that were susceptible, knowledge that if you were over the age of 70, there was, 5 to 10% chance of being in hospital, and a 1 to 2% chance of dying, and that got higher. So we kind of had no choice but to go into emergency mode, and the Australian public reacted very well to that. And I don't think the politicians, I honestly do not think federal or state politicians ignored the science. I think the decision-making became much more complex as we went along, as we learnt keeping people at home for a very long time, closing schools, marginalised communities that had to keep working, the mental health effects, the business effects, all of the complexity of how you make decisions, science. I mean, one really good comment, which I really believe, is that public health is political. Public health is not about just a scientific decision making. The best thing to do to avoid COVID is to stay at home and never go out. That was clear. But public health is weighing up all of this complexity of the impacts, mental health, economic, all the rest of it, what we were trying to achieve. So I don't think the politicians, and my experience was that they always listened, but the decision making, there are lots more threads into the decision making as we went on, and the community had very strong views as well, and so all of that had to be adapted. At the beginning, the community were very happy to, trust science, trust our leaders. Many countries didn't have that level of trust. But as time went on, a lot of people had different opinions. So my approach didn't really change.
Right. Okay.
I'm not making public health policy. I'm a scientist. I've got access
So you sort of felt that the science was heard the whole way through, and it was just that different priorities were being overlaid over the top, and it's
and those decisions were not easy to be making.
Okay.
Yeah.
Let's move on to the second topic, although I would love to keep going with this one. First Nations Australians. Tell us briefly how you went about it, but then what did you learn? And what were the surprises, and what are some of the things that we could take from that, either back into the mainstream response or into the next pandemic?
Yeah, the story of COVID in First Nations communities is a really interesting one, and a really good one. Every infectious disease is far higher in First Nations communities compared to non-Indigenous Australians, embarrassingly so. Like rates of gonorrhea about 100 times higher in Indigenous people compared to non-Indigenous. Rates of TB, rates of chlamydia, many infectious diseases. Actually, HIV is one that is higher, but it's only marginally higher in Indigenous communities. And Indigenous communities have also, of course, had a terrible history of infectious diseases having major impacts in killing many people in the early days of colonisation. But in COVID, and I'm just talking about 2020, 2021, where we were very different from the rest of the world, numbers of infections in Indigenous communities were low, and it never really ripped through Indigenous communities, which is what we were most scared of. And it's thought that happened because the response was Indigenous-led. And so you had communities that were Indigenous leaders making decisions about what their communities were going to do. That sounds pretty obvious, but apparently that was done very well during COVID. And I'm not an expert in Indigenous health or in Indigenous communities, but my involvement, and maybe you asking this because a prize received a philanthropic gift in about April 2020. It's from the Paul Ramsay Foundation, specifically for a prize to do relevant research on COVID in Indigenous communities. And it was $2 million, the whole of a prize, but this whole network in pandemic preparedness was, a $5 million grant, which is really nothing once COVID hit. This was $2 million just to focus on First Nations issues. And we, within the original grant of a prize, we'd had a stream of First Nations activities which was led largely by First Nations people. So we asked them, Christy Crooks and Adrian Miller, what should we do with this funding? And what we did was we had an entirely Indigenous-led allocation of the funds. Only Indigenous researchers were eligible to apply. They established a National Council of Indigenous Leaders as an advisory body, and that's what we did. And so I think that was really, and there were some fantastic insights into understanding Indigenous communities' attitudes to vaccination and staying at home and many, many other things. So I think the key there was Indigenous leadership.
And if we were going into another big pandemic now, would you then take that, and you were giving advice to government, would you say, therefore, we might want to talk about creating local leadership throughout the community rather than having it led from the centre?
I mean, that does.
Is that the conclusion to be drawn?
Yeah. I mean, that does exist in Australia. You know, there is a National Association of Indigenous-led healthcare, NACHO, just for what the actual acronym it stands for, and there were specific groups within the federal government that were leading and advising on Indigenous affairs. So I think that was happening, but this was an unusual experience in COVID, an unusual outcome. I should also say the HIV story is very similar. The HIV story in Indigenous communities is a good one, meaning that Indigenous rates of HIV, although slightly higher than non-Indigenous, are much less than many other First Nations communities around the world. And a lot of that was, of course, Indigenous-led.
But that's not the question I asked. The question I asked was, what can we learn for how we respond in Werribee, or how we respond in Frankston, or how we respond in Malvern from our experience with how we respond in unknown land?
Well, I think what we learnt in COVID is that
the answer could be nothing, by the way.
What we learnt in COVID is you can't tell people what to do. We didn't learn that in COVID. We knew that in public health. You can't tell people what to do for a very long period of time. And you need community voices to reflect the understanding in diverse communities. And we didn't have that at our fingertips when a crisis hit. So I think what we learnt was that you need to have those structures around community advisory bodies, etc., in place, because very hard to build them at a time of crisis. Yeah. Right. I mean, a great example here was the high-rise apartments that we had that terrible situation with in North Melbourne, and top-down approach, and not enough time, or that's not an excuse, but there was little engagement with leadership there, which eventually happened, but it was difficult to happen quickly.
Mind boggles as to how you would actually create that sort of community relations to be ready in the future. It's very
I think it's doable.
Problem.
I think it's doable, and it can be done. I mean, what we did in COVID was in my world, in the world of virologists and immunologists and clinicians, we leveraged all of the expertise that all of those groups have in other infectious diseases that we deal with day in, day out, just that it doesn't hit most of your radar screens, but we deal with it day in, day out, with HIV, with viral hepatitis, with influenza outbreaks. And people have got very well-honed skills that were then applied to this new virus. And I think you can use the same principle around public health with communities that are maybe focused on one area, and that they can be, and you get the community literacy and trust, and then you can pivot that to a new area. You can't, and that's pretty much the principle around pandemic preparedness, that you can't sit and twiddle your thumbs for the next pandemic, but there's lots and lots of work to be done in the inter-pandemic period.
Building these community networks. Well, let's go to the third topic. the leadership of the Doherty. So that there were a couple of things. Firstly, that amazed me when we talked. The first thing is the amount that the Doherty achieved, right? So you grew the virus, first lab in the world to do that. You developed a vaccine, you ran some clinical trials, you developed biomarkers for pediatric COVID, all that, right? Then you did a whole lot of really interesting operational things. You set up the testing network for Victoria. You ran all the early testing for the state. What else? There was a couple of other things. Do you want to add to the list?
We did remote testing in what called a lab in a van. We developed saliva as a testing tool, lots and lots of stuff. And did the genomics. So genomics was the fingerprinting of COVID as it spread throughout the community to determine that it came from the quarantine hotels. I hate to say this, but we were the first lab to demonstrate that ivermectin has activity against COVID, and then ivermectin in a test tube model at 1,000 times the concentration. Then ivermectin became a global movement for anti-vaxxers. Don't give me a vaccine, I want ivermectin. But ivermectin doesn't work, but everyone wanted ivermectin. So we did a lot. And of course the modelling. So probably the most visible work was the work that the Doherty led on modelling, which had a big influence on government policy, opening and closing borders. Yeah.
So there were three things about that as I thought about it that amazed me. Right? The first was at the time when everyone in the society was going very much inwardly focused and trying to work out how to be, how to manage themselves and manage their families and protect themselves, you had all your scientists working at 100% efficiency. And so that was the first thing. The second thing was that you had a group of scientists who, where in science the coin of the realm is creativity and collaboration, and the Doherty, big parts of the Doherty became basically a production organisation where it had to be about coordination and efficiency, which means that people have to think and work in completely different ways. And the third is that for a typical scientist, you have 2 years from after you have a result before it gets published and it's been through several rounds of peer review, and then you announce what you found and no one actually gives a damn anyway, no one's interested. And then you have all these scientists who are publishing their science the day after they get the results with no peer review and full public scrutiny by everyone, including the Murdoch press. Sounds to me that there are some, well, I suppose there's two questions. You've got time for two questions. So the first question is around, we'll do that one first. So tell me the leadership story here. What was involved in making it up? Well, the word we'd probably use is safe. How did you and your team get the institute working on this completely different footing?
Well, there's a good leadership story here. I'll start by saying that the people that are in those areas that did all those great things, this was their moment, right? A brand new virus. And so most of them, as Mark remembers, there was an element that was incredibly exhilarating about learning about what was happening, translating it, and giving better outcomes to our own community. So I think there was incredible exhilaration by people to make a contribution. The flip side of that is that people were working 24/7, 110, 20% of the time, largely driven by their own commitment to humanity. I mean, it sounds corny, but there's no doubt about it. People were in crisis mode. So a big leadership challenge was around about making sure that, trying to stop really significant burnout. And that, of course, is because the message that no one person is going to save the world here. This is a really big group effort, and all you can do is continue to say that and I hope model the behaviour. But for me, one of the most important leadership lessons, and which I thought worked incredibly well, was around communication. And so I actually was in Chile when the first patient was diagnosed with COVID. It was my husband's 60th birthday, and we were hiking in the remote part of Chile with absolutely no internet or phone or anything. So I wasn't here at that very moment that the virus that we diagnosed. I knew about COVID, of course, because it was late January now, but I wasn't here on that day that the virus was grown, and there was a huge interest in it, and things were heating up. And it was now February the 1st, and Australia closed the border with China. And when I got back to work on February the 2nd, on the Monday, the first thing I did was I got everyone in the room, we were meeting in the room at the time, who was doing anything on COVID. And there was about 30 odd people at that stage that were thinking about modelling, that were doing the diagnostics, that were in WHO meetings overnight. So we got, and I asked people that we would meet every single day and tell everyone what you're doing and tell everyone what you're hearing, and that we were all going to hear the same information. And that was really, really invaluable with how we communicated externally, because all of us had access to the same information. And it meant that you could have very clear messages externally that weren't we weren't all saying different things externally. I wasn't micromanaging the commentary. It's just we were using the same sources of information. And we pretty much met met daily for most of 2020, every day, 8:30 to 9:15. And then we slowly reduced the frequency of it. So it was that intense communication. And then there were, of course, leaders. You know, the Doherty is a big institute. It's got over 900 people. There were leaders in the particular areas of diagnostics. We run 2 major diagnostic labs, and they had whole teams under them that were doing the military-like response to build. One example is VIDRL, Victorian Infectious Diseases Reference Lab, which is the biggest public health lab in the country, is in the Doherty. They normally would do 100 PCR tests a day. That would be their normal pre-COVID for HIV, for hepatitis B, others. And so they had to ramp up to 3,000 a day very, very quickly until the private labs came in and took over, who eventually got to 100,000 a day. We would never be able to have done that. So there was some level of coordination on that scale up. So one amazing thing about the Doherty was we were able to sort of move PhD students from other parts of the organisation who were doing research work into these public health labs. So we had this mobile workforce. So there was some of these service stuff was operationalised by people whose job it was to provide diagnostics for Victoria. But another area that worked incredibly well in the early, I saw my role was to try and get as much money for people to do their work, and that really changed what we could do very early in the pandemic. I wasn't going out spruiking for money, but there was a huge interest from the community, and we did very well on philanthropic generosity of people from our community and internationally. Actually, the first big grant we got was from the Jack Ma Foundation. Jack Ma's the richest man in China, and because it was seen as this China problem, and that because we had funding that allowed us to create teams to address research questions that people would work on together. And there was a ready source of money. Very, very different to how you normally fund research, where one person has an idea, writes the grant, gets the money, whole process takes 9 to 12 months, carefully spends that money. It really drove collaborative research. A very unique situation in time.
Cool. Great. Thank you. And then the final question is, so you grew the virus, first lab in the world to do that. If it's a quick and interesting answer, why the Doherty and not any of 50 other labs that are in the same space? But then the more interesting question to me is, you then decided to give it away, to not take any commercial position in what you'd created, and basically free source the public to make the science public domain. And I'm curious to know, how did the fact that science was public domain shape or change the rest of the global response?
Yeah, so the first question, why the Doherty, why were we able to grow the virus? Again, this was done within VIDRL, the public health lab, and the technical reason is because viruses grow in different types of cells. Vidral are growing viruses all the time, so they have a panel of 20, 30, 40 different cell types, and they put it on one particular cell, which is the monkey kidney cell, a Vero cell, and it grew like wildfire. And it was a bit of luck. There was no reason it should grow on that cell, but because they had all of those cell lines at the ready, and very few labs now grow viruses because we do everything by PCR. We just look for the genetic code of the virus. We don't grow it. But it's still a very valuable capability that only specialised laboratories do, such as a public health reference lab. And it's good we do it because we can then study how the virus, how it behaves, what cells it infects, what drugs works against it. So these are very specialised techniques that we have to have available in Australia. And it is because we've had decades of investment in this sort of capability. So it was a bit of luck that we actually, the team knew that no one else had the virus because they had been on calls right through January with a global network of similar labs. No one had the virus except China had the virus, actually, and they hadn't shared the virus. And no one could grow it. But actually, we learned it was actually very easy to grow, but it had to be in these particular monkey cell lines. The story about sharing it is an interesting one. As I mentioned earlier, I was in Chile at the time when in this remote, in Patagonia, when the first case was diagnosed, but then was in Santiago when it was grown. And Mike Catton, who was then the head of Vidral, he'd been head of this public health reference lab for 25 years. And I've told this story publicly before, even though it doesn't reflect very well on me. When he rang me to tell me that they had grown the virus and what a big deal it was, which I knew, he also said, and we've decided we're going to share it with everyone who wants it. And I said to him, "Are you sure about that? We could wait a week and you could fully characterise it, and we could understand what cells it grows in, what to block it. Would it be a paper in Nature or Science? And would it really matter that we didn't share it?" And I said, well, have a think about it and let's talk about it tomorrow morning. So because the time differences, and I was thinking I was making a really wise move for the Doherty and for science, and why not, let's quickly characterise it and then we'll release it anyway. And he rang me back the next day and he said, I've decided, he was my deputy actually. He said, I don't agree, and I think we should release it because this is going to have a huge impact on public health. We know that many groups around the world want it. It will mean that you will get to work on diagnostics, therapeutics and vaccines immediately, and I'm going to do it. And I said, and I was convinced by that stage, and it was 100% the right decision. It was 100% the right decision for public health. It was 100% the right decision for us as an organisation because it was a values-based decision, which is really what was the right decision at the time. And so, I say it openly. I was thinking this is a great opportunity for Mike and for Vidral, but actually it was the right decision. And the Institute benefited enormously from that, not only because we shared the virus with so many labs, but it gave us very high visibility very quickly with government, which was very helpful, with philanthropists, and that additional money fueled lots of great research. So Mike was 100% right. So you've got to stand up to your boss sometimes when you think you know better, and he definitely knew better. And he, of course, works in public health, 25 years. I don't work in public health. I'm a physician and a researcher, so I have a very different perspective, but he was 100% right. Very glad he did it.
Fabulous. Now, before we open up for questions, I'd like everyone to turn around to the person next to them and spend a couple of minutes talking about what you're going to take from what we've said so far and translate it into how you're going to change your practice as an innovator or innovate your practice as an innovator. Okay, so we'll give you a couple of minutes to that, and hopefully that'll provoke interesting discussions and we'll get more interesting and exciting questions in a couple of minutes.
Good idea.
Okay, so given that, now you've had a chance to have a bit of a chat. Why don't we open the floor to questions? There are 2 mics at the front here. If you want to stand behind one of them and ask your questions, and see what Sharon does with them. just walk up to the microphone. Hang on, hang on just a second.
It's for the recording, yeah.
So I recall that you mentioned that in the Indigenous communities it was quite successful how they handled their approach, but wasn't sure about what the specifics were. You mentioned things like their thoughts about vaccines, how to stay at home, how they listened to their leaders. What were those actual steps that they took, and how did it differ from, I guess, the non-Indigenous community, and what are the lessons what were the exact lessons learned, and was it feasible at scale for non-Indigenous communities?
Yeah, I'm not sure I can comment too much about that, but one of the key factors were remote communities and quarantining remote communities. It was a similar principle around quarantine, not allowing people in or out, and that was really made the big difference about not bringing the virus in. For Indigenous communities in urban settings, I don't think there were the significantly different outcomes as compared to what happened in rural things. So a lot of it was just around isolation.
We seem to have decided to innovate the questions. There's some microphones that are coming in. So one, Costas here, behind you there's a microphone. And then Jack. Speak. If you speak, it'll go by magic.
This one? No. This one here works?
Yeah, it works.
Take this one. I'm not going mad.
Do you want this one? This one works.
That's right. I'll take this one, but I will sit down. Can we talk about digital technology? So I think we all had experiences with the COVID tracking app. I think that emoji of the face palm was invented for that. So we talk about readiness for next pandemics. It appears to me that connecting with the communities that you described earlier, yes, we can go through the leadership groups and voice our concerns or ideas, opportunities to leaders that then present to other leaders, and we're playing these whispers. Where could we have used digital technology better? And where does this feature in any learnings or roadmaps for what we do moving forward? Because, again, from a very biased standpoint, you'd think that we can use the same software that we use in research to help us communicate better, get information to and fro faster. I'd love to hear your thoughts on that.
Yeah, you raise a whole interesting angle on the pandemic response that I must admit I haven't thought much about recently, or didn't mention at all. And of course, all that tracking to help with notifications, the entry into places that we were doing with the barcode, and how every single place had a different system, and it was different from New South Wales, and I don't hear much discussion at all about that. And you're so right that is absolutely key. I think prior to COVID, there was a belief that no one would have ever allowed, the community would never have done it, because it was all this issue about privacy and private information and tracking. But people took it up because they had to take it up, but it was done so clumsily. So it's not something I hear a lot discussed, but it's hugely important. And of course, how we use data, full stop, in Australia was not state of the art at all. A consequence of being a federation, people's views around sharing data, and that has to get better. What I can say is that some countries did it really well. So Korea was one example that did the remote tracking very early in the pandemic. Of course, we gave that all away later on. I mean, you have to also keep it in perspective. At the beginning of the pandemic in Victoria, we were still using faxed reports of positive cases, so there was a major revolution in how data was managed in our notification system over the course of 2020. But yeah, the role the community could play with uploading data and contact tracing, it is super important. It was not done well, and definitely something that needs to be focused on. And I honestly do not hear much talk about it. And we often talk about diagnostics, therapeutics, vaccines, but it's the diagnostics that there's so much more than just the physical taking of the sample, how all of that. And yeah, really important part for the early response.
To connect that with the response program?
Yes, yeah, definitely. And I mean, we've all forgotten a bit about it because it became less relevant, of course, once we were trying to stop disease, not transmission, which, happened post-vaccination. So from the end of, early 2022, we're already, the stuff you're talking about is super important for early acute response. And huge, people will use these things, as we learnt. And people from COVID as well, more and more are familiar and comfortable with electronic communication. So it's definitely an area that needs to be thinking about. Definitely we can't go back to what we were doing.
I really like that question a lot, actually. I'd love to kind of take that further, but I'll go back to perhaps an easier question, but it's probably up to you in terms of your response. Thinking back and looking back, what are some of the key lessons learned for you? What would you have done differently if you could do it again, or for the next pandemic? What would you anticipate you would do differently based on what didn't work well?
Well, I think I'll just use two examples of what didn't work well in Australia. I'll just talk about Australia, not sort of as the global response, because there's a lot more I think we need to think about what happened globally. I don't think we dealt with data well and shared data and real-time data and using it to inform decision making, and therefore using data then to explain policy. And that's because of some of the issues I spoke about before. And I don't think we did that well in coordinated research around the country. So some countries had a very top-down approach to research. It was like, we've got a huge problem. These are the top 4 priorities. Go work it out and work together, and we'll give you money in these 4 areas. It's sort of what the UK did. I mean, but the UK also didn't have a fantastic public health response, so they had a brilliant research response. And we didn't do that. We did, as a country, we kind of went back to the usual ways we fund research, and we gave small amounts of money through a competitive process, which all took time, and it all led to people competing with each other. And one particular area was in clinical trials. So we had lots of clinical trials around the country rather than the UK having one big one. So I think the research response, and the research response, well, isn't just a value add in a pandemic. The research response was absolutely critical to find new diagnostics, therapeutics, vaccines, to tell us what we were doing was working or it wasn't working, to inform policy. It was a critical part of the public health response. And I look at other countries that managed that much better than Australia did.
Thanks. There's a female hand in the back. Excellent.
Hello, thank you. It was very, very insightful. I just wanted to know your thoughts and comments about the CDC in Australia and what you think that will mean.
Yeah, so the Labor government came to power with a promise to establish an Australian Centre for Disease Control. They haven't told us a lot about what it will look like. In the last budget, there was an announcement of $90 million for the first 2 years for the establishment phase. They've done lots of consultation and have largely said the CDC will focus on both communicable and non-communicable diseases. it may or may not focus on international or global health or regional health. That's still, to me, not clear. They've said it won't do research, but will partner with research organisations. But I think the most important thing, the CDC, they want to also be a single voice of truth. And actually that is really hard. I don't think government, it's a very hard thing to be a voice of truth at a time of crisis. So I'm not sure that how they're going to achieve that. That's going to be hard. But I think one thing the CDC can and should do is deal with this issue we have around data access, data sharing, data analysis in real time, and really look at countries that did this very, very well. I said the UK. Israel did this very well. Portugal did it very well. Qatar did it very well. You know, they're all slightly different countries to us. And a federation is not a reason why we can't do it well, because the UK did it across Wales, England, etc., in some of their data systems. So I think the most important thing will be the data, because data informs policy. And I think also we've got a very literate community who want to understand why things are being done. And I think data helps explain that to people if it's told in the right way. So we're all very interested to know what the CDC is going to do. I think it's a good thing. I hope it's not going to be just business as usual, and they'll really be able to pull some levers that haven't been pulled before.
Terrific. We have a hard stop because there's another event in here at 5:30. So I'd like to invite David Collette to come and give a vote of thanks. David is the Melbourne Melbourne manager for SMEC. State manager for SMEC. Some of SMEC built the Snowy Mountain scheme once, and now they're building it again, and they do a lot of other big engineering projects in between, in renewables and in urban development, things like that, and probably many other things. But from our perspective, they have been a phenomenally valuable sponsor for our program. They have been in since the second semester, because in the very first semester, David's daughter was one of our inaugural students. They have been very good at
part of my brief story, but that's okay.
They have been very good at hiring students out of the program, which is something that we like very much, and the students do very much as well.
I'm looking at another one right now.
And they also, as a result of participation in the program, now fund a lot of our clubs and societies, which all the other sponsors in the room, you are welcome to follow them in sponsoring more projects, hiring more graduates, and contributing more money to things like students and clubs and societies. And finally, they are sponsoring the drinks and canapes and things outside for the second half of this evening's event. So with that, David, let me pass over to you.
Thank you, Peter. And what I will say to that is Peter can be, thank you. Peter can be very convincing arm twister when he wants to be. Thank you. That was an absolutely, as an engineer, non-medical person, somebody who was on the receiving end of COVID, I found that in my suit, rather than doing something proactively as you were to help rectify the problem. That was a fascinating glimpse into that world, and I'm sure that we all are taking a lot of insights back about how to manage crises. And we all, I guess, certainly our business, we managed a crisis through that ourselves, getting thrown into lockdown for a couple of weeks and then being forgotten by the authorities. And I'm not pointing the finger here at all, I'm just saying that was an example of technology failing us as a business and trying to lead 200 people who were, where's my call? I need to get out. So that was fascinating, and thank you very much, and please join me in putting our hands together. I did want to very quickly give a shout out to the IPP program. As Peter correctly said, we've been involved since semester 2, 2017. My daughter came home one day and said, "Dad, I'm doing this amazing course. You've got to get involved." And so she connected me with Peter and a couple of others in the program. We had a meet, and I think we started off with 2 projects in that first semester together. We're up to, I think, our 19th. We're doing our 19th right now, so we've done a lot. Now, you work out the number of semesters. And so at one point during the COVID crisis, we did 4 projects simultaneously, which I sponsored all of them together. And when COVID hit, I remember a conversation with Peter, and he's panicking. I don't know what we're going to do. We deliberately designed this course to be impossible to teach online. Impossible. And, you know, I think necessity is always the mother of invention, and they innovated, right? Name of the course. And I actually think we all took something positive out of that experience. So we learnt as a business, hybrid working is fabulous and it's here to stay. And we've evolved our business to accommodate that, and it's a win-win for our people. And certainly the IPP program is run at least partly hybrid now, and so we've all taken a great deal out of that. I meet with our student teams. I've got another meeting with the student team. Matteo over there is leading. Wave to the group, Matteo. Got another meeting with them tomorrow. Some will show up in person, some will show up online, and I'm cool with that. And I think that's a great lasting legacy of the program. But Peter, thank you for the opportunity to say a few words. Please join us for the drinks and canapes and lots of conversation just out in the lobby. Thank you very much.